Welcome to the External Medicine Podcast. My name is Daniel Belkin, and I'm here with my co-host and brother, Mitch Belkin.
We're both medical students interested in non-traditional ideas and innovation. This podcast is our attempt to explore topics currently on the outskirts of medicine, topics not widely accepted by the mainstream, but that we believe merit a closer look.
This podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution.
If you'd like to support us, follow us on Twitter at EXMedPod and sign up for our newsletter at externalmedicinepodcast.com/subscribe.
All right. Today we are interviewing Professor Emily Oster, who is an economics professor at Brown University, where she studies health, behavioral, and development economics. She received her PhD from Harvard and previously taught at the University of Chicago Booth School of Business. She is the author of 3 books on pregnancy and parenting. Those are Expecting Better, Cribsheet, and most recently, The Family Firm.
In this episode, we discuss Professor Oster's approach to analyzing studies. We talk about the data behind the purported benefits of breastfeeding, as well as the rise in the U.S. C-section rate over the past 50 years. Before playing the audio, we want to give a bit of background on the 2 main topics. So, Daniel, why don't you tell me a little bit about breastfeeding?
So, the CDC and the Academy of Pediatrics currently recommend exclusively breastfeeding your infant for 6 months and then continuing to breastfeed while introducing food until they're about 12 months of age or older.
Would you say that your mother followed the CDC and American Academy of Pediatrics guidelines here?
She did not. She did not. I'm sure that explains a lot.
So basically, breastfeeding is good.
Yes. And these recommendations are based on a bunch of studies demonstrating the purported benefits of breastfeeding. So I'm just going to run through some of what can be listed on sites if you go looking for benefits of breastfeeding. The benefits for the baby are said to include decreased risk of asthma, fewer ear infections, fewer respiratory and GI infections, lower rates of obesity, lower rates of type 1 diabetes, higher IQ, higher wages in adulthood, and a bunch of other stuff for the baby. And then for the mom, the benefits of breastfeeding are said to include things like lower risks of ovarian and breast cancer, decreased risk of type 2 diabetes and hypertension. And this is all, of course, on top of all of the emotional benefits.
So looking online on the Cleveland Clinic's website, they list some of the benefits, which include the following. Breastfeeding produces the naturally soothing hormones oxytocin and prolactin that promote stress reduction and positive feelings in the nursing mother, increased confidence and self-esteem, increased calmness. My personal favorite, breastfeeding can support the wellness of body, mind, and spirit for the whole family.
Breastfeeding is this increasing the self-esteem of the baby or the mom?
Wellness of body and mind for the whole family.
Interesting. So what does Emily Oster think about breastfeeding?
Well, Daniel, I'm glad you asked. So Professor Oster in 2015 wrote an article for 538.com, Nate Silver's website, titled "Everybody Calm Down About Breastfeeding." And in that article, she basically argues that some of these claims are overblown or based on relatively weak evidence. And most of the problem comes from the fact that these are observational and case control studies that don't fully adjust for the differences between women who breastfeed and those who choose not to. As you can imagine, women who choose to breastfeed are a little bit different than those that choose not to. They tend to be wealthier. They tend to be more highly educated, and at least in the developed world. And being wealthier and being more educated are already correlated with better infant outcomes, independent of whether or not they breastfeed. So it's somewhat difficult to draw causal conclusions from some of this evidence.
Yeah, interestingly, there was one randomized control trial on breastfeeding. It's called the Probit Study. or the Promotion of Breastfeeding Intervention Trial, which was a randomized control trial which took place in Belarus in the 1990s. And they took 17,000 healthy mother-infant pairs of full-term singleton infants and randomly assigned them to either an intervention arm that encouraged breastfeeding or a control group that just had the usual infant feeding recommendations.
It's sort of weird to me that the only RCT is from Belarus in the 1990s. Like that's kind of crazy.
It's the only place that would do it.
So
are you gonna let me talk, bro?
Bro, why are you always trying to steal my thunder on the Mitch Belkin podcast?
All right. So do you want to say the results, Mitch?
No,
should I say the results?
You should say the results.
Okay.
Makes you feel big. You didn't get the breast milk, but you didn't get this.
That's harsh, man. So at 12 months, infants from the intervention group were about twice as likely to be breastfed compared to the control group. And at 3 months, the intervention group was 6 times more likely to be exclusively breastfed. It's like 43% to 6.5%. The intervention group also had a significant reduction in the risk of gastrointestinal tract infections. This is 9% to about 13%. And also atopic eczema. This is about 3% to about 6%. However, there was no significant reduction in respiratory tract infections.
So wait, that's interesting. So basically these absolute risk reductions are like 3-4%. But sometimes when people talk about this study, they'll say that there was a relative risk reduction of eczema and GI infections by 30-50%. So it sounds a whole lot different saying these big numbers for the relative risk reduction, whereas in fact, the absolute risk reductions were relatively small.
Yeah. There are very few people out there convincing anyone to breastfeed by saying, your baby will get maybe like 4% fewer gastrointestinal infections. So now let's change gears and talk briefly about the other main topic in this interview, cesarean sections. Mitch, where does the name cesarean section come from?
Well, Daniel, I'm glad you asked. So there are a lot of different explanations about where the word came from. One is that Julius Caesar was actually born by C-section. Probably not true because his mother Aurelia, the name of which I just looked up on Google, died long after childbirth, and the chances of her surviving after a cesarean section pre-Joseph Lister were nil. So other etymological explanations include the root of the word coming from a similar root as the Latin verb for to cut. But basically, I don't know where the word came from.
So what are the reasons that people get C-sections, Mitch?
I can't believe you don't know the answer to that question, bro. You're a 4th-year medical student asking me, why do people get C-sections? Well, C-sections are a surgical procedure used to deliver a baby through an incision in the abdomen and uterus, as I assume most of our audience already knows, usually performed when a vaginal delivery presents increased risks for either baby or mom. Some of those medical reasons could be things like prolonged or abnormal vaginal delivery, twin pregnancy, preeclampsia, breech birth, fetal distress, and problems with either the placenta or the umbilical cord. Back in 1970, about 5% of all births in the US were by C-section. And in 2019, the CDC's official C-section rate was 31.7%.
So that's like a 6-fold increase.
Yeah, it's pretty substantial. And it's not exactly clear why the rate has gone up so much. There are a lot of different theories out there. And I guess we should take a minute and just list some of the possible reasons. This is by no means a comprehensive list, but these are some of the reasons to give people an idea.
Yeah. So one reason is an increase in the number of high-risk pregnancy over the last few decades. There's been a rise in obesity rates, diabetes rates, preeclampsia, hypertension. And on top of this, women are giving birth at older and older ages. So in 1970, the average age of a mother giving birth for the first time was 21. And in 2017, it was nearly 27.
Another reason that could explain the increase is increased litigation and the fear of litigation leading doctors and hospitals to favor policies that lead to more C-sections. Malpractice premiums are positively correlated with higher rates of C-sections. And that may mean that in circumstances where there is concern about things going wrong, doctors may opt to do C-sections because it's a more controlled procedure. This is particularly true with VBACs, vaginal birth after cesareans, because failed VBACs can lead to serious complications, including uterine rupture and neonatal morbidity.
Another factor is the advent and increasing use of continuous fetal heart rate monitors, which have been demonstrated to increase the rate of C-sections. Numerous studies comparing continuous fetal heart rate monitors to intermittent auscultation reveal similar outcomes for babies, but intermittent auscultation reduces the C-section rate.
So another reason that could possibly explain some of the variation in C-section rates over time is increased patient preference for C-sections. Now, there's not a lot of literature out there that I saw that strongly supports this claim, but there is at least some reason to think some women would prefer to have C-sections.
Another factor is attending preference. So there are studies showing an increased number of C-sections just prior to the end of shifts and just before lunchtime, where it's hard to imagine a physiologic reason that C-sections would spike during those times.
Another reason that may account for a small increase in the number of C-sections is breech births. So there is less and less training on how to do breech births vaginally. So more physicians opt to do C-sections that maybe in the past would have been more comfortable with a vaginal delivery.
And finally, another reason for increased C-sections might be higher physician and or hospital compensation for C-sections versus vaginal births, which might lead to hospital policy changes which incentivize physicians to perform more C-sections. This gets talked about a little bit in this interview, and we will link to an article in the show notes about this. Anyway, so these are just some possible reasons. It's obviously a very hotly debated topic, and we by no means get to the bottom of it during this interview, but we hope some of this information is helpful before diving into the episode.
And now we bring you Professor Emily Oster.
We are here with Professor Emily Oster. Emily, welcome to the External Medicine Podcast. Thank you for joining us.
Thanks for having me.
Our cousins, who all recently had babies within the last year, are huge fans of your work. But for someone who's unfamiliar with your work, how would you describe what you do?
So I'm a professor of economics at Brown University, and I write books about pregnancy and parenting, which use data to try to help people think about the choices that they're going to face when they're pregnant or when they're a new parent or even an older parent. And my books are kind of some combination of, I would say, memoir and meta-analysis. So they do a lot of data and a lot of sort of helping people work through the decisions, but in a way that hopefully is readable.
Do you have any financial disclosures to make?
No.
So you've written 3 books on medicine-related topics, including pregnancy, childbirth, child rearing. And some people may think of these topics as ones that their doctors should be advising them on. What would you say to people concerned that these books are giving medical advice?
So my books are really about data, not about being a doctor. And so I think that's the sort of expertise that I come with. So my training is in data analysis, is in causality. I have publications that are about statistical methods. And that's the lens that I bring to these problems, along with the lens of being, a pregnant person and a parent. And so sort of trying to kind of help people navigate that in a way where they can understand what the data says, and almost to help them come to their interactions with their doctors in a more informed way. So I think in some ways, like a lot of the service I try to provide in this book is like, hey, yeah, that's right, I'm not a doctor and neither are you, but many of the people who read it, but this is a way to understand the choices you're going to be asked to make and to come to those choices on a more even footing. And I think I would also say, like, this kind of data analysis that's not field specific, like their data is what it is, and the ways that we understand it are not somehow like only available to people with particular kinds of degrees.
Could you tell us a little bit about how you became interested in development, health, and behavioral economics?
So, I was drawn to economics initially. One non-financial disclosure is that my parents are economists, and so I sort of knew about economics through that. And I was drawn to studying it myself in college because I think it is an interesting way to answer a lot of different questions about the world. And I really like data. I've always really liked data, and that's a kind of sort of central piece of what a lot of economists do these days. And so when I think about sort of the topics that I've worked on, a lot of it is driven by, here's something I'm interested in, here's a data set that I think is interesting. And early on, I did a lot of work in developing countries, a lot of which was about health. And later I've done more work in the US, which is about health. And I'm sort of constantly driven by trying to understand how people operate and how people make decisions and how people think about their health. And I think in a lot of ways that's motivated almost all of my research, and some of my other writing also.
In 2005, you published an article linking decreased female to male offspring ratios in China with hepatitis B. And then 3 years later, you published another article which argued that your previously published paper was mistaken and that actually the offspring ratios had little to do with HBV. This seems like a really beautiful example of the scientific process and action. Was it hard to change your mind? And why do you think this type of public change of opinion is so rare?
I wasn't hard to change my mind. It was hard to admit I had been wrong, I guess. I mean, once you sort of see I remember, getting the follow-up data. We spent a lot of time collecting some follow-up data. And then I remember getting that and seeing it and, realizing, oh, crap, now I'm wrong. And I'm going to need to say that publicly and say that in a responsible way. And that was very, that was very challenging. And, when you do that, then, some people are like, oh, it's so great you did that. And some people are like, I knew you were wrong and you're a liar. So it wasn't like I think ex post, like in the kind of later realizations of that, most of it has been people saying like, it was great that worked out like that. But in the moment, like there was definitely a lot of the other stuff too. And I think partly that is why this is less, that is why we have like an instinct to dig in. I also think in a lot of these sort of academic debates, it takes this was an example of a time when, for whatever reason, like there was a fact and we were able to then like find out if fact was right in a way that was not that it was easy, but once we had done it, it was like either this fact is right or not right. And like, that's kind of it. And I think in a lot of these debates, that's sort of less true. And so it's a little easier to kind of continue to convince yourself that you're right, even when it seems to other people like maybe you're not right. So it was a hard few weeks.
Yeah. Changing topics just slightly to your 2007 TED Talk that you gave on HIV in Africa, you argued that some of the campaigns like the Abstinence, Be Faithful, Condoms campaign were in fact not as responsible for decreasing HIV transmission as increases in life expectancy that led individuals to make safer choices about their sexual practices, which in turn led to less HIV transmission. I'm curious what you think are the implications of this for US in terms of public health policy and how we actually frame discussions.
Yeah, so I did a couple of things. One was about HIV, and then a sort of later paper about Huntington's disease, which is around sort of testing. Is a very basic theoretical idea in economics that if if people have a sort of longer overall life expectancy, that they will be more interested in investing in various ways, in education, in job training, but also in avoiding illness, right? And so if you sort of think about like what is the risk of doing something that could lead to mortality. Well, the sort of size of that risk, the importance of that risk is much smaller if you are otherwise if your life expectancy is otherwise curtailed. So the HIV example was one, but maybe a more obvious example is the paper on people with who are at risk for Huntington's disease, which is a degenerative neurological disorder with a large reduction in life expectancy. And we looked at things like, was that group more likely to smoke? And it turns out like that's a group that's much more likely to smoke than much less likely to quit smoking than sort of comparable people who are not who do not have Huntington's. And that's, as you think about like what's the downside of smoking, it's one of the downsides is lung cancer. Well, if your life expectancy is 45 or 50, that lung cancer is actually not the major risk. So if there's other reasons to smoke, you would be more likely to do that. And so that's a sort of like it's the kind of theory that economists have that people find sort of kind of yucky, but I think nevertheless does seem to be supported in the data. In terms of sort of how we think about that for public health, there's a sort of positive spin, I think, where we can say, look, this means as you invest in as we invest in people to improve their invest in I don't know, like health infrastructure to improve life expectancy either in the US or abroad, that's sort of self-reinforcing, that if people are kind of going to be healthy, if they know that they have a chance of like living for a long time, they're going to be more incentivized to invest in their health and on their own. And I think that's there's kind of a reinforcement of that may be productive.
So your books include very well written, easy to understand descriptions of evidence for and against different health or medical decisions. For example, you examine, caffeine during pregnancy, alcohol during pregnancy, breast milk versus formula, circumcision versus no circumcision. And surprisingly or unsurprisingly, the evidence ends up being, in general, more complicated and nuanced than many people might expect based on rumor or public health messaging on these topics. My question is, on any contentious topic where you can get different viewpoints and everyone seems to have their study which they point to that proves their point of view, what is your process for looking through the scientific literature to find which studies are actually worth basing your beliefs on?
So my process is mostly reading them. So I sort of do this in kind of like two tranches. So one thing is I basically like try to go through and read, like sort of go through the entire literature, look at all the meta-analyses, look at all the like consensus opinions, look at all the individual papers. And so, in a lot of these cases, there'll be a sort of many tiny, terrible papers and a few sort of like large scale things that you want to learn something more from. So I spend a lot of time doing that. I also sort of simultaneously will have other people, particularly on these like very big topics, sort of have some research assistant pull everything. So we make sure we kind of have like a sort of full accounting of all the papers. But I think, in a sense, where what I'm doing would differ from a more traditional kind of meta-analysis, and is in some ways closer to a consensus opinion, except that I'm only consensusing with myself most of the time, is that I actually try to identify the papers that I think are good and give them a lot of weight relative to some other papers that are not, like, I will basically have no weight to things that I think are not good. And so I think in some of these places you'll sort of get into something and realize, like, yeah, there are a million papers that correlate IQ and breastfeeding, but most of them are terrible. And most of them, we are just not learning anything, except that there's a correlation between, the kinds of people who breastfeed and the kind, like, and other things. Like there's a million papers like that. And so you can sort of say, well, I read 50 papers like this. Okay, well, they're all garbage. So you could read 100 papers like this and they were all garbage. The challenge there is to figure out, what are the papers that are less garbage, that are not garbage, and what do we learn from those? And I think that's the part of my process. It's both a little bit harder to describe, but is very central, and is the part that is like really deeply informed by the fact that, like, at the end of the day, this sort of like data analysis, thinking carefully about causality, like, is my job, is the sort of the academic thing that I am best trained in, because it is what lets me sort of think about, okay, these are the 3 like important papers in this space that are actually like telling us something and getting to some sort of deep underlying truth. And then here's the kind of the vast unwashed that we should not be focusing on.
Did you ever end up unearthing a study or a few studies that you found very convincing that other people in the medical field just had not looked at all or hadn't talked about a lot?
Yeah, I don't think there's too much of that. I think it's more like I throw things away that they don't throw away. I think one place where this comes up some is, in the something like the breastfeeding case, you will have, like a little bit of randomized controlled trial evidence, and then a lot of like kind of like garbage correlations. And then you have this other category of studies, which we can talk more about if you want, where basically we look within family. And so sort of compare like 2 siblings, one of whom is breastfed and one of whom is not, but have the same family. And that is a sort of empirical approach that's much more common in economics. Actually, many of those papers are like in fields like sociology or economics rather than sort of published in medical journals. I think that I give sort of more weight, more attention to those than sort of some of the medical space would. And I think I kind of understand why that is, which is that within economics, within sort of social science, we spend a lot of time with observational data, and we spend a lot of time differentiating between sort of approaches to observational data that are better and worse. I think sometimes in medicine, there's sort of like RCTs and other, and like RCTs are great and all other things are like kind of not as good, and we're not spending a lot of time in that in those literatures talking about within the category of other, there is actually a huge variation in quality and a huge variation in how much you would want to conclude that something was causal. And I for me, there is more variation here. So I think I some of the time I'm kind of pulling on parts of the sort of non-experimental evidence more than others might.
So since we're talking about breastfeeding, can you describe the Probit study, our one randomized controlled trial on breastfeeding, and also maybe give a few examples of good and less good observational studies on breastfeeding?
So the Probit study is a randomized trial. It's that was run in Belarus in the 1990s, early 1990s, and they do what's called an encouragement design, where there's sort of their incoming people who are giving birth are divided into 2 groups. One group is encouraged to breastfeed. The other group, it's not that they're just like not encouraged. So the idea is that you encourage people and their breastfeeding rates will go up. And they do find that the breastfeeding rates are higher in the encouragement group than the other group. I think it's something like 30 percentage points higher at 3 months. So it's like a sizable effect, but not sort of infinitely large. And then they're looking at outcomes both in the short and long term, sort of short-term health outcomes, things like digestion and respiratory illnesses and so on, and then sort of long-term outcomes like height and weight and IQ and all that kind of stuff. And what you get out of that, I think, is so what you see in that, which I think is kind of consistent with a broad reading of everything else, is that there's pretty convincing, or there's evidence of a reduction in gastrointestinal illnesses and in allergies and eczema. Those reductions aren't, again, they're not huge, although the sort of treatment effect is not enormous either. And so you have to kind of figure out, like, since there's only a 30% increase in breastfeeding rates, maybe even a small decrease in gastrointestinal illnesses is actually kind of large. So there's sort of that piece. but then many of the outcomes that they are looking at, like IQ and weight and this kind of stuff, like basically don't show up as kind of, we do not see large or really much in the way of any significant effects on those kind of outcomes. So I think people read that as kind of like pouring some cold water on some of the claims there. When you then sort of dive into the like vast unwashed of the observational literature, I often contrast like two studies of IQ. So there's like tons of stuff on IQ. So you'll have like sort of one study. There's like one study from Sweden where they relate how long kids were breastfed to their IQ, and they sort of show that their enormous gain, 7 IQ points, 10 IQ, some enormous number of IQ points, but they're kind of able to adjust only a little bit from like maternal education and kind of not at all for other things. I'll often draw the contrast between that and papers that use like the National Longitudinal Survey of Youth in the US, which the structure of the data allows us to not only control for maternal IQ, which already has a huge impact on the size of the effect. So if you adjust for how much education mom has, that lowers the breastfeeding effect some. If you adjust for her performance on an IQ test, it lowers it tremendously. And that is because IQ of mom is correlated with both baby IQ, kid IQ, and also with whether they choose to breastfeed or not. If you then look in those studies within families, you compare 2 kids where one of them was breastfed and one of them was not, same mom, you get basically no effect. And so I think that kind of a lot of the literature ends up lining up like that. And in the end, it sort of looks like there's, some the sort of gastrointestinal effects early on are probably real, maybe some ear infection effects early on, clearly large benefits for preterm babies, again, around like NEC. I'm never very good at pronouncing the name of that complication. And then, probably some benefits for the mom in terms of breast cancer, but a lot of this like long-term stuff that gets cited is really not supported in the data. Sorry, it was like a very long answer to that question.
For the NEC, that's necrotizing enterocolitis, which is in premature infants more so than in older.
Yes, almost exclusively. And I think that turns out to be, so breast milk is very helpful at avoiding that complication.
In terms of the twin studies that you referenced, when you're weighing the evidence of the RCT versus observational trials, like some of the twin studies.
It's not twins, it's siblings.
I'm sorry, siblings.
Yeah. It's important because like the twins where one is breastfed and one is not would actually not be a great study, because you got to like wonder like why is one breastfed and one not. That's also, you wonder that with the siblings, but it's less of a problem.
Wonder if there'd be an ethical problem with that IRB. We're going to randomize these twins, one to breast milk, one to formula.
Something tells me that you're not getting that. Maybe your IRB is more flexible than the one here, but I doubt it.
What about the benefits for mom? Does breastfeeding help you lose weight, have a lower risk of depression, cancer risk? People don't talk about that as much, I feel like, but it's something you bring up in your books.
Yeah, so I think the one sort of compelling argument there is around breast cancer risk, where it's both that there's a fair amount of sort of supportive evidence from reasonably good studies with basically fairly good controls, and there are some concrete mechanisms. So there are some reasons to think there would be reductions in breast cancer risk. So that's probably the one. It's kind of the one that shows up in the data. A lot of this stuff, like you're going to be skinny and everyone's going to like you, and that's just like not. We don't see that in the data. The weight loss is not a weight loss free birth control activity.
So what would you say is the most compelling reason for someone to consider breastfeeding? And what would you say is the most compelling reason to not breastfeed?
So, I mean, I think that, we sort of approach breastfeeding we approach breastfeeding with new parents with a sort of frame of like, this is the best start you can give your baby. And don't you want to give your baby the best start, or do you do you want to give them just a crummy crapo start? Is that what you just want to give them a bad start? That's fine. Yeah, you can give them a bad start. But if you want the best start, I think we put so much pressure on this. And so I think that there's a kind of like very early, when I was doing research for Cribsheet, my mother shared with me like her copy of, must have been like Dr. Spock from like 1977 or whatever, like before, that she was reading 1880, which I was born. And he has this discussion of breastfeeding. It's like so nice because it's like, this is a time in which people were sort of getting back into the idea of breastfeeding after sort of the nadir in like 1970, it starts coming back up, but it has not taken on the, like, this is the best start. And if you don't do this, you hate your baby kind of tenor that we have at the moment. So what he says is like, great reason to try breastfeeding is that you might like it. Some people do, and it might be something that you enjoy and that works for you. And I think like in some ways that's the pitch I would say, like, you might like it. And, it's actually like, if you like it, it's like super, it's super convenient. And I think about like my own experience with this, which is like with the first kid, I felt so much like I had to do this because it was like something to achieve and because it was like very, very important and it was really high stress and it was not something, I did not like it. And it was a lot of, like, it was just like a lot of emotional drain and a lot of unhappiness associated with this sort of time of life that's already pretty high stress. But then with my second kid, I did like it, and I would have said, yeah, like that was super convenient, and like I was glad that I did it because it was like it was easy and I liked it. So I think it's kind of like that's the frame I would like us to put around this. Like maybe there are some small benefits early on. You might like it. It's a good thing to try. It might work for you. Like let's give it a shot, but not like if it doesn't work or you don't want to do it, like not give people the impression that this is, making them a bad parent.
That's actually one aspect of your books that I really like. You present the data and you essentially say people have different values and will value things differently and make different choices ultimately. It's very much you should choose what's best for you, understanding the risks and benefits of every decision. I think that's something that's oftentimes lacking from some of these discussions.
Yeah. And I think it puts, like part of it is that when we are parenting, we really want to do a good job. Like it's very important to us to do a good job because we all really care about it, which is very nice. But sometimes it's like we want to do a good job so much that we think everyone else should make the same choices because that's how we can be sure that we did the good job. And I think that leads to some of this sort of like judgmental tone that is probably not helpful.
We want to move on to talk a little bit about C-sections. And a few months back when I was on an OB-GYN rotation, I was a little bit shocked at what percentage of the women in labor and delivery ended up having C-sections. I think at the hospital I was at, it was officially around 40%. And when I did just a little bit of digging, in the 70s in the US, there was something like 5% of all births were by cesarean section. And then currently it hovers somewhere around a third. In 2019, you wrote an Atlantic piece on C-sections about why the C-section rate is so high. So what is it that you think the reason behind this is?
There are a lot of reasons. I don't know if maybe my thinking has evolved since then. I think there's a lot of reasons that C-section rates are high. So, some of them are sort of unavoidable. People are older. If you're older, you're more likely to have a C-section. And I think that obesity is probably a risk factor that's also gone up. So there's a bunch of pieces like that are kind of contributing to this. And then I think there are things that we are doing medically where we are probably doing more C-section. We are certainly doing more C-sections than we need to. And the question, I think, in part is whether we are doing more, like how you would find the ones that you shouldn't have done. And I think that's sort of the hard part here, is to basically be like, okay, our C-section rate is like 35%, and we think like realistically it should be 20% or whatever, like whatever number is the number that we think we should be getting to. But like, where are the 15? Like, what are the 15% of people who shouldn't do this? And we sort of know that some of this is happening because people just get tired of waiting for like people to have natural, like for like labor to move forward. And so I think, we had, until relatively recently, actually, when I wrote Expecting Better, we were still in this like sort of idea that there's a standard labor curve of like 1 centimeter an hour. And if you're going too slow, like then you get a C-section. And like subsequent, when I was researching Expecting Better, I sort of went into like, okay, where do we get that number? And what is the more recent data? And in fact, the more recent data was like, that's totally not like, maybe that's right on average, but it's certainly not like people click along like a Swiss clock. You can kind of take 4 hours to do this and 45 minutes for this. So it's like, we just needed a lot more flexibility in those guidelines, and they did update those guidelines in the sort of subsequent period. And now maybe we wait a little more. So I think there are some things like that where we're not very patient, and you can see in the data, the lack of patience with things like, C-section spike right before a shift ends, C-section spike right before lunch, like sort of like things that look like, I'm just kind of like, I just like want to, get this over. And then you also see things that look like, for example, continuous fetal monitoring. So, which is like, actually, I think leads to increase in C-sections without much gain in terms of infant, of infant or maternal health, because again, it's sort of like people almost like, you overreact to patterns that are basically fine that you wouldn't typically see, but when you see it on the computer, like it's hard not to react to. And there's a sort of defensive medicine aspect of some of this, which I think gets into this. And then I think sometimes people want them, right? So there's like sort of exactly how important is C-section by maternal request, I think is not totally clear in the data, but it certainly is something that, that comes up.
Yeah, the fetal heart rate monitoring is interesting because I remember learning, everyone in my OBGYN rotation, all the attendings and residents, were aware of the meta-analyses which show that the only thing that fetal heart rate monitors do is increase the C-section rate. They don't really have any other benefits. Yeah. And when I then asked the question, so then why do we use them? They were like, what? Like, of course we have to use them because we need to know if the kid is hypoxic, or once you have the information, it's kind of hard to close your eyes again. It just didn't compute.
Yeah, no, I think I always wanted to say like, yeah, people are like, well, more information is better. It's like, I guess, but like you need to use the computer. Like if you're going to get all this information, you need to feed it through something that won't overreact. So it's like, you can get the information, but then the computer needs to tell you like whether you should be looking at it or not. But once you have it, I think, once we have this, there's a sort of feeling of like, well, what if even one infant was saved by this? And I think that's a very hard, very hard to talk about that.
So you mentioned an ideal C-section rate, and in looking through some of this data, it's interesting that WHO has an ideal C-section rate, and I guess I'm just very curious, how does one calculate what an ideal C-section rate look like?
I assume that they made it up out of thin air. I mean, I don't know I don't know. I have never been able to figure out where they got that number from, and I don't know how you would get that number. And I've spent a lot of time talking to doctors about it, and nobody has, people who do this on the ground, like nobody has any particular idea. It's definitely not zero. And it also seems likely based on, that it isn't 35%. But, how would you know it was 15% or whatever number they've picked? I don't know. There are some things you could do, like you say, okay, we should be doing C-sections for breech babies. That's some share of babies, not 15%, what is like 4%, something like that. And so, okay, there's that. And then maybe there are some other particular complications you should do this for. And so we could sort of add up to that. But I don't think it's really, I don't think that they could really defend the precision of that number with anything in data.
The breech birth is also something that's interesting too, because current OB-GYNs in training, at least at the institution I was at, are not taught how to do a breech birth vaginally. So there is sort of a fall off where people now are increasingly reliant on the C-section because it's deemed dangerous to do that. And now people aren't even trained to do it, so they're reliant increasingly.
No, that was it. I mean, I find that the sort of dynamics of that, like sort of what happened after the term breach trial are very interesting, right? Because we sort of had a trial. It was like, okay, now we've decided like we got to do C-sections or breech births. Actually, when you sort of look at the data there and then you look at the follow-up, really doesn't, it's not like the evidence is overwhelming in favor of, it certainly doesn't suggest that it wouldn't, that you would want to completely close off the option for a vaginal birth, or at least not sort of engage in some discussion or shared decision making. Like, what if I said, like, I'm planning to have 16 kids, and like boy, like 16 C-sections is not gonna take, right? So like maybe that's a place where like just it feels like somehow there would have been a place for talking for saying, look, in some breach situations, frank breach, other kind of things that might make it work, a trial of labor could be reasonable. But because we sort of decided, okay, we're not doing that anymore, then nobody learned to do it. And then it's not like, as I understand it, as the person who's never delivered a baby in any position, my sense is that like, actually it's pretty hot. It's like, it's something you would want to learn to do. It's more complicated than just the regular way. And so if we don't teach people to do it, then we definitely don't want them to do it. And then if you went back and you evaluated, is it a good idea to do a C-section? You almost certainly would find it was, because now what you're going to find is there's a bunch of people who know what they're doing vaginal. No, you don't want that, right? So now I definitely wouldn't want to do that.
You mentioned one of the reasons for C-section is the labor curve. People just don't want to wait any longer, or they go outside the traditional bounds of how a labor is supposed to progress. And one of the ideas that you brought up in this Atlantic piece was increasing the rates of reimbursement for vaginal births to the level of a C-section rate. What are your thoughts on actually changing reimbursement to try to encourage physicians to do labor in certain circumstances?
Look, money is always incentives are always a complicated tool. And no matter what way we structure the incentives, people will respond to them in ways that we don't like, right? So if you tell people like, we're going to pay you more to do a C-section, they're going to do more C-sections. If you tell you we're going to pay you the same amount to do a vaginal birth and a C-section, they're going to do more vaginal births. Maybe they do more, they may do too many of them, right? Because actually, like in terms of the cost of the hospital, like in terms of other costs, like the C-sections, like, I don't know, it's more, whatever, there's other stuff that you have to do. It's like more expensive in some ways. So from the standpoint of like, if we said we're going to pay you the same amount, we might get it like an overcorrection, right? So you sort of, and then people would say, well, I don't think we get that much of an overcorrection because actually the sort of like the malpractice incentives go kind of continue to push the other way. So like, we're always going to have that push. And there's just like a lot of ways in which the way that we pay for healthcare incentivizes really weird stuff, which is maybe not the stuff that we want to get, or not exactly the outcomes we want to get. And even linking, you say, well, okay, now I want to like pay you the same or pay you in this particular way, and I want to incentivize you to do a good job by like, I'm going to pay you less if something bad happens, or I'm going to pay like a bonus if good things, whatever it is. Well, that's going to generate a whole other set of weird incentives. So, I do, that was one thing that we mentioned. I think that the guy Spencer I wrote this with is like very, like, I think he thinks that's an interesting idea. I think it is an interesting idea. It's not it's not a silver bullet because it has the sort of opposite problem.
I'm reminded of the door to balloon time where hospitals are rated at, if somebody has chest pain, in terms of having them come in, giving them an EKG, if it's positive, rushing them off to a cath lab. And that length of time is monitored and hospitals are graded on it. And unfortunately, by actually monitoring those times, you have this weird incentive where maybe you're just going to start catheterizing people that wouldn't have needed it previously, just because you're trying to lower particular time.
Yeah.
Reaching back to our previous discussion on your work with life expectancy, you mentioned Huntington's and HIV. Do you think there's a case in the for, instead of targeting C-sections with financial incentives, to focus on correlates with C-section like obesity or other correlates, and trying to drive those down as a proxy, but in order to ultimately decrease C-sections?
I think that I don't think that's going to be a good approach relative to relative to sort of like, there's the kind of incentive part. Then there's the like, let's change sort of practice. Like, let's not do continuous fetal monitoring, things like that, which I think, let's like not let people do more of these before lunch or whatever. Like, there are some things we could sort of do in the hospital that probably move the needle a little bit. But the two main risk factors for C-section, other than having had one before, obviously, are obesity and being old. And I don't think we're going to lower the kind of age of first pregnancy. The assisted reproductive technologies are going to keep pushing that number up, I think. And in terms of the obesity, there's a lot of reasons we would like to lower obesity rates well beyond this particular sets of issues, but that's like really hard. And I spend like a lot of my professional life thinking about how people, I have a paper about how people change their diet based on grocery purchases after a diabetes diagnosis, and the answer is like one less soda a week. Okay, and this is like people who's basically like a quarter of their spending is in the categories of like sodas, desserts, sweets, and candies. And then it's like, basically you get like, and that's like that's like your own diagnosis of, you know what I mean? Like, you're like, this is like, you have diabetes and you're still like, I don't know, I like candy. And I mean, it's totally understandable. People like it, people like the diet, like habit formation is really important, all this stuff. But to say that like somehow, like, that's problem is so hard and so intractable.
Yeah, a lot of people, when they get diagnosed with diabetes, will say, oh yeah, I'll stop drinking soda. I'll just drink twice as much orange juice.
Right, exactly. It's like, that's not going to help. That's not going to help.
One interesting thing I learned from your article was that physician patients actually have lower rates of C-section compared to non-physician patients, which suggests that OBGYNs treat their physician patients differently in some way. Why do you think that is?
So I think there's two pieces of this. I'm not sure it's about So one is that I think my guess is they get listened to more. That like, if I said like it's important to me not to have the C-section, like that's going to carry more weight. I think it also may be that the patients themselves are differently informed and maybe like more interested in it, like they may have a different approach to this. But I think I have a very distinct memory of when my second kid was born. He had jaundice. And they did a blood, it was like very borderline. We way overtreat jaundice, which I hadn't sort of recognized at the time. But anyway, like we way overtreat jaundice, but fine. So they said, you have to come back and like have him in the stupid container and whatever it is. And, and in the initial conversation about this, I was trying to understand from like the doctor who had called us, who's not like our typical doctor, she's whatever, some other person in the hospital, like, I was trying to understand what is the cutoff, like how close are we to the cutoff, would it be okay to like see how it goes for another day, like how where are we in the like emergency space here. And she was basically just like, I don't know why you're questioning me, like your kid could have brain damage, which like, by the way, was not right in this situation. But it was like sort of very dismissive, like, I don't know why you're asking me all these questions. And then we ended up going to the hospital. I want my kid to have brain damage. And, being there overnight. And when she came in the next morning, she told me, we figured out who you are. And now I think we can work together. And then she was basically like, we're trying to get you out of the hospital as quickly as possible. Everything's totally fine. But it was like this moment where I was like, it was like very jarring, because of course, in some ways, like that was great, I got to get out of the hospital. But also I think what she was saying is like, okay, now, like, I understand that you're like a person with a PhD, maybe you're very difficult. Who knows what other things she figured out about me. It was something about like, okay, well, you're a person that like I can have shared decision-making with, but like, that's not right. Like we should have shared decision-making with everybody. It shouldn't matter whether I'm like a whiny person who like goes on the podcast and says that you're a jerk,
Yeah. So I want to be respectful of your time. We have a few rapid fire questions here. So I'm going to just ask away.
Do it.
What are one or two of the most important papers that have come out in your field of economics, public health, development economics over the last like 20 years that people who are outside your field should be more familiar with, and why?
So I was just looking at it this morning. So I'll pull on a paper by Amy Finkelstein, Matt Genskow, and Heidi Williams, which is about the question of whether the variation in medical spending across locations in the US is about supply or demand. So is it that like the people that sort of like McAllen, Texas is very expensive because the people there are like very expensive, or because the doctors there are like doing too many things. And there have been sort of various views about this over time. And this paper has a very, very clever way of getting at this by looking at people who move and asking whether basically when I move to a place that is more expensive, do I get all the way more expensive to like to my new location? Do I stay where I was at my old location? And it turns out it's like 50-50. So in fact, like some of this is, maybe that answer is not that interesting, but like the empirical approach to this is very interesting, and suggests that sort of some of why some places more expensive than others is that the people that they're treating are more expensive, but some of these sort of differences in cost are about something that sounds like sort of supply driven, like, you know, doctors are doing the same things in for more expensive, for more money.
Do you have an opinion on the transparency laws around hospitals? Do you know what I'm talking about? That the Trump administration, what are your thoughts on increased transparency and what we've seen in the data around that, if it's actually helping drive down costs in any way?
It doesn't drive down. I think they think to the extent we've seen things, it doesn't help. I mean, I think we'll need to see more about this over time. I'm not sure it drives down costs that much. I think part of the issue is that like the people are not the payer, right? So like if everybody paid out of pocket all the time, and I think for the things where there is some component of that, there may be more value to this transparency. I think, you know, when Medicare is the payer, it's not clear that there's like, so it's not clear that that's exactly going to help.
What important economic truth do very few of your colleagues agree with you on?
Oh, I think I'm pretty mainstream in my economic truth views. You know, I think economists are like remarkably, it's not a very good answer to your question, but like I think economists are like remarkably aligned on a lot of things. I mean, there's sort of individual questions that people would disagree on, like, you know, how important is SNAP for nutrition, like sort of stuff like that. Like it's like an empirical question. We could have a disagreement. I guess one thing where I'm probably sort of on one particular side of it is in the question of kind of how rational are people in their choices. And I think I probably have like less faith in individual rationality than some of my colleagues. You know, you spend enough time like looking at people's diets that, you know, it's hard to come down on the side of like everyone's just optimizing all the time, not optimizing.
So which of your 3 books was the most fun to write, and why?
So the books are so like, so Cribsheet was the easiest, and probably in that way the sort of most fun, because I had a very, very clear vision about exactly what I wanted it to look like. It like, you know, it's not that it's not hard to do these things, but like it was sort of like the hard things about books are like, how does it get structured and what is it, you know, and by the time I got to writing Cribsheet, I had already written a book. I sort of knew what it was like to do this. It was just like, here's this topic, I'm going to figure out what I want to say about it, I'm going to like say it, and I had very clear idea about what the book was going to look like. So that was certainly the easiest. And I think in that sense, probably the most fun. The most recent one, which is about older kids, probably the most challenging, because the sort of how to talk about decision-making was different than the other books.
Of all of the medical topics that you've researched in Expecting Better and Cribsheet, which finding was the most surprising to you based on what you previously believed before looking into the literature?
Bed rest. Like I hadn't really thought about, some of it is like many of the things in the book I sort of researched as I was doing it. So by the time I got to writing the book, like even if it had been surprising before, it was like not surprising then, but I was never put on bed rest. And so when I got into the bed rest thing and I was like, oh my God, we're putting like, 20% of people on bed rest, and actually bed rest is like just total terrible idea with a lot of negatives and no positives for basically anybody. That was a surprise.
Yeah, when we get our like USMLE step 1, step 2 exams and it goes to some orthopedic question, there's always a possible answer, which is bed rest, and it's always the wrong answer.
Yeah, it's like, because the thing about bed rest is like, it seems good. Like you just like lay down.
You're resting. Yeah,
you're resting.
Yeah.
You should rest.
Yeah.
And it's like, no, don't rest.
Yeah. Yeah. Now it's like, get out of bed as quickly as you can and walk around and don't rest.
Rest.
All right. So we just have one more question for you. In your most recent book, The Family Firm, you describe different types of parenting strategies. What do you make of the Judith Rich Harris argument that parenting style doesn't really have any effect on children's long-term outcomes like IQ, personality, income, test scores, that sort of thing?
So I think that there's a sort of interesting, she's not the only person to argue this. There's this kind of like generic argument that that kind of, it doesn't really matter what you do as a parent. And I think that in some ways that's right. And in some ways it's tremendously wrong. And so I think the way in which it's really right in the data is like a lot of the choices we make aren't really going to matter. Like, once you're kind of a person, there's usually the example of people who write to me and they're like, should I send my kid to Montessori preschool where all the teachers have master's degrees, or a play-based preschool where only 2 of the teachers have master's degrees, but they're into early childhood? I'm just like, look, once you're the person who's thinking about that, it doesn't effing matter which preschool. You just like whichever one is closest to your house, like try not to think about this. And I think there is a sense in which like many of these choices that seem really fraught in the moment of making them, actually like this is like on the margin, if you're providing like a stable, happy home that has some books in it where your kid feels safe and they feel like they're loved and they have opportunities to think about things like that's, if you're doing that, then all this other stuff is like kind of noise. But that piece is really important. And we think about sort of like broad-based inequality across the US. And we think about like the importance of the first few years, the importance of childhood, the importance of sort of equality of opportunity. It would be a mistake to say, well, it doesn't matter because like everybody has the same, like everything is the same. None of these choices are important. That actually it is really important that we like appropriately scaffold and we give opportunities to kids. And so a lot of that stuff does matter. It's just that it kind of doesn't matter for the people who are most obsessed with it, is almost how I'd put it. So I think there's I worry that those arguments are used to be like, well, we don't really need to provide any like help to poor people, but actually no, like that's not what that means at all. But it does mean, that a lot of these things we're obsessed about are probably not so important.
Gotcha. So before we close, is there anything you would like to add about any of the topics that we've discussed?
No, this is great. This is super fun. Thanks, guys.
Yeah, thank you so much for joining us today. If people are interested in learning more about what you think about all these topics, they can go online and buy your books. They're all available on Amazon and probably other places, but Amazon seems to be where most of us buy our books these days. But
indie bookstores.
Yeah. They're on the way out now, but
yeah.
But yeah, I've really enjoyed reading your books. I'd recommend them to people. And if people would like to learn more about you and your work, where should they go on the internet to find you? So
the best place to find the stuff I'm like doing so I have a website at Brown, but I actually have a Substack, like a newsletter, which is probably the best place to find out what I'm thinking about at the moment, which is mostly COVID. So it's called Parent Data and it's on Substack.
Right. We are subscribed to that and it's great. So we can also recommend that. Yeah. So thank you so much, Emily.
Perfect. Thank you guys so much. This is great.
Thank you. Take care. If you'd like to support us, here are some ways you can help. Subscribe to this podcast wherever you get your podcasts. Leave us a review, preferably a phenomenal review. Visit us at externalmedicinepodcast.com and tell your friends.